Welcome everyone to Frontier's quarterly Frontier Nursing University IHI presentation. We are very fortunate today to have with us Dr. Mary Dolansky, and I'm going to just give Mary a little introduction here. Dr. Dolansky is an associate professor at the Francis Payne Bolton School of Nursing, Case Western Reserve University, and senior faculty in the Veterans Administration Quality Scholars Program, Louis Stokes Cleveland, Virginia. Dr. Dolansky is director of the QSEN Institute, Quality, Safety, and Education for Nurses, and an international community of healthcare providers using quality and safety competencies in both academia and practice. She has co-published 2 books on quality improvement education, co-authored several book chapters and articles, and was guest editor on a special quality improvement education issue in the Journal of Quality Management in Healthcare. She served as co-director and is now Director of Interprofessional Education Integration of the VA Transforming Primary Care Center of Excellence. She is faculty member on the CWRU Macy Foundation Interprofessional Education Grant for the pre-licensure students, and she is co-author of the massive open-line online course, MOOC, Take the Lead on Healthcare Quality, that has reached over 15,000 learners across the world. So I'd like to welcome Mary here, and we will have her go through her presentation and then answer questions all at the end. So Dr. Dolansky, I'm going to mute myself and hand it over to you.
All right, thank you very much. It's really a pleasure to be on the call with all of you, as you are quality improvement enthusiasts. I was mentioning to Judy and Diana earlier that I was cued into Frontier Nursing because I was an IHI Open School abstract reviewer for the posters last year, and I noticed how many really solid presentations were coming out of Frontier Nursing University, and I was like, something's going on there. So I may be preaching to the choir tonight, but I'm here tonight to share a little bit about my quality improvement enthusiasm. And I do believe we are, though, at somewhat of a crisis out in healthcare right now, where we do need some superheroes to really move the quality mission. And maybe all of you are those superheroes already in place. Someone maybe needs to mute. All right, good. So I just want to share my real favorite person in the world, and that is Abe Lincoln. And that's because he was an improvement philosopher, and he had so many failures in his life, and every time he would come back and do it better the next time. And that's sort of the philosophy I have as a nurse and even as a person in my family life and in my professional life, in that whenever, failures come by, I see it as an opportunity to just do it better again in the next round. So I am an improver. I do have this vision that every healthcare professional will go to work not just to do their job, but to think about how they can improve the work that they're doing. And actually, I have my family engage in quality improvement. My children are older now, but when they were younger, we did actual fishbone diagrams as to why they did not do the dishes. And we did team meetings every week. And we also did run charts on their actual behaviors so that we could monitor when they were actually meeting their goals and when they weren't, so we could problem solve to figure out how they could do it better. So you can imagine they're not really too enthusiastic right now about team playing and improvement in their lives. This is just a little bit about me. I've always really wanted to learn and do more with improvement. I served as a magnet director and have done a lot of interprofessional teaching, but always really focused on improvement. And I do direct the QSEN Institute, and it was a Robert Wood Johnson funded study back in 2005. It was funded by RWJ with $6 million. And RWJ wanted nursing faculty to develop competencies for quality and safety so that we could help nurses nursing faculty to help students to meet those competencies in the curriculum that they provided. And at the time, the QSEN was to provide comprehensive competency-based resources to empower nurses with knowledge, skills, and attitudes necessary to continuously improve the quality and safety of healthcare systems in which they work. So back then in 2005, they really thought the issue was with nursing faculty, that they didn't have these contemporary quality and safety teaching strategies. But it turned out then through the evolution of the last 12 years that we found that even practicing nurses don't really have these competencies. And these were the 6 original QSEN competencies that came out of the Institute of Medicine's report. And you can see they are, pretty standard concepts that we probably all really have a good handle on. But I think really the key is here thinking about these concepts or competencies in the framework of systems thinking. And that is, I think, the paradigm shift, that most nursing schools teach a lot of linear thinking and tasks of what nurses do. But I think the key for us in nursing is really to move the paradigm and shift to this systems thinking, connecting the dots from what we do to the consequences that ensue. So this is the one QSEN competency for quality improvement, and you can see here it lists knowledge items and skill items and then attitude items. And I think that these really have been important dimensions for us as faculty and even as students to really try to focus and target our work. And this is a shot of the QSEN website, one example of the resources that are on the website, and that is the teaching strategies that are there. We have about 170 teaching strategies on the website currently. This is a great place for you as students in the DNP program, or if you're a faculty member, to submit a teaching strategy. They're peer-reviewed, so you get a publication with it, and it's also an opportunity to share some of your expertise in teaching any of the QSEN competencies. We're also starting to populate some strategies for practice, where we're really trying to spread the QSEN mission to nursing orientation programs in practice, residency programs, also in clinical ladders. So some of those new practice strategies we're starting to populate into this web-based registry. You can also see some of the other resources on the website include some other kinds of faculty resources, such as videos that you can share, and also our conferences are all on here, and the presentations and posters from past conferences. So there's a lot on the website that can be used by both faculty and students and practicing nurses. So what has QSEN accomplished in the past 12 years? Well, actually, the QSEN competencies are the foundation for the National Council of State Boards of Nursing Residency Programs. They also are a foundation of many specialty organizations, such as the operating room nurses and the oncology nurses. As we all know, they sort of were developed around the same time the essentials for undergraduate and graduate education were created. And QSEN is in many, many textbooks, and actually the concepts of QSEN are integrated into the NCLEX exam. I think about 22% of the NCLEX is focused on quality and safety competencies. And so Linda Cronenwet was the PI for the original RWJ study, and Shirley Moore is my mentor at Case Western Reserve University, and she was also one of the founding QSENistas, as they call them. And they just are really terrific, I think, scholars in quality and safety, and really have moved this mission very rapidly. So in 2012, then QSEN's grant funding ended with Robert Wood Johnson Foundation, and then the project shifted to Case Western Reserve University, and then we sort of gave it the name QSEN Institute, just to brand it in a little bit of a different way. But basically, we're doing the same thing that they did the past, prior 10 years, where we continue to have conferences. This past year it was in Chicago, and next year it'll be in Bonita Springs in Florida. We then also keep the website going that has resources and teaching strategies. And we also started in the past 2 years task forces. We really felt that the way we were going to spread the mission was really through a village and not one or two individuals, that we really needed a village to move this. And the village model really is these task forces where we have about at least 10 to 30 nurses on each one of the task forces, and the task forces meet each month, and they're doing some spectacular things. The practice task force has received an AHRQ grant for the last conference on implementation science. They also did a conference at the ANA, Quality and Safety Conference, back in 2016. They did a pre-conference there to talk about how we can implement these competencies into the practice pieces, such as in orientation programs and clinical letters. And then the academia task force, they are doing currently a 10-site research study where they're looking at the effectiveness of one of the QSEN teaching strategies that relates to feedback and looking at its impact on incivility and the reduction of incivility. We now have an international task force that is represented by about 20 countries in the world. Our VA quality scholars also are a task force, and that is a fellowship, a 2-year fellowship through the VA where you are devoting your time to quality improvement work. And we also have a DMP and research task force. So those are some ways where if you're really interested in this area, you could really come on board and get involved and do some publications and grant writing. And this is just a slide of the massive open online course that we developed to help other schools to be better able to teach quality improvement in a more structured format. And that is on demand now. You can take the course at any time. And this is our worksheet that we use to help to structure the way we teach the quality improvement in the massive open online course. And as you can see, the first side of the worksheet are 3 steps. And I love this worksheet because, as you all know, because I know you're doing QI work, the beginning parts of improvement work are labor intensive, and we're always thinking, let's just get to the intervention already. But the key to success is really this problem identification and really doing baseline data collection, forming your team, looking in the literature, asking other places how they're doing things and what's working for them. And then really taking a very deep look into the system and identifying processes and looking at the system components of this. So I love this worksheet because always my students are jumping to want to say, well, I think we should just try this. And I'll say, no, back up. Got to go to the first side of that worksheet and go through all these steps before I'll even gonna let you try an intervention. And then this is the second side of the worksheet, which then finally gets to a specific aim where you are targeting somewhat of a clearer direction and intervention, and then identifying your measures, your process outcome and balancing measures. And then step 6 is where we've really been focusing a lot more, and this is where the QSEN conference focused on, and these are the implementation strategies or change strategies. And I've been doing some work in this area and really pleasantly surprised to know that there are about 85 different kinds of change strategies or implementation strategies that are evidence-based that we can now integrate into our quality improvement work to have more success. Because I think that the statistics state that only about 30–40% of QI projects really are successful and sustained. And then look, the last step, 7, that's when finally you do your Plan, Do, Study, Act. So it does take a while to get to that intervention stage. So that's the worksheet that we use in that massive open online course, and I find it to be very helpful. I also just wanted to briefly talk about medicine because they are moving very rapidly in QI work also. They have integrated quality improvement into all of their levels of medicine, from medical students to residency to continuing education. And their main competency is the systems-based practice and practice-based learning and improvement, where they're really trying to get medical students to really have this philosophy of change and improvement. So that's just the same thing I've just said. And then why do I love quality improvement? I think because it targets these aims of quality where we ensure care is safe, that care is effective, and that that care is efficient. And then I also love QI because it's helping us to make care timely for our patients, so there's no waits or delays, and that really we're thinking about our patients and creating patient-centered care and care that is equitable. So whenever students ask me, well, what really is quality? I always go back to these 6 quality concepts, really to solidify their projects. And really, the reason why I love QI is because it's systematic and data-driven. It brings immediate improvement because I don't have a lot of patience, but I think I really like it because it's a philosophy. Always thinking about how can I improve, how can we improve, and I love these tools of improvement. I use them everywhere, as I mentioned, even with my kids. And now it's so exciting because quality improvement is moving towards a scientific discipline where now we're studying, how is the use of champions as an implementation strategy better or not as good as using coaching. So now we can start to kind of sort of do some experiments and to find out what really works instead of just shooting arrows at a target where we're not really sure what is effective, just bundling up everything and saying, well, we got to do 10 things in order to get this to work. But maybe we really don't have to do 10 things. Maybe it's just 2 things. We're just not sure which 2 they are. So I look back in history. I like history, and Codman was our father of quality. And the little story here is that he was a surgeon, and he used to carry index cards with him in his surgeries. And after it was over, he'd write down some notes, and then he would observe his patient go through the recovery period and then document on his cards if the patient was successful or not. And he would learn through these cards. Well, the story goes that he showed his cards to his colleagues, especially for the patients who died, and his colleagues really said, don't be showing those cards to anybody. We don't want to know about your patients who died. But truly, he had that spirit of inquiry and spirit of quality that I think we all really need. And as you may know from your faculty teaching UQI, Florence Nightingale is the improvement goddess, or mother of quality, and the reason is because she kept such great data, and these charts that she kept were really way before her time, and most of the interprofessional our colleagues really look to Florence as one of the QI experts. Another theorist I really enjoy reading about is Edward Deming, with his theory of profound knowledge, and I can't really go into it, but if you look at his concepts of his theory, they're right on with really what we need to do in improvement, and those are to look at the system, to really understand our data, to understand this theory of psychology. How do we get change and behavior change, and then doing these small experiments. And the Deming Institute is still alive and well. So there are many like-minded people, like all of us, really trying to improve the care we're delivering. So with that, I just want to briefly go over the current state of healthcare, and then talk a little bit about the culture of improvement, and then briefly talk about some superhero solutions as to how we can achieve a quality of improvement in our healthcare systems today. And the history of quality isn't that really old. If we go back to 1999, when the to error is human came, we really are just sort of novices in our improvement efforts. But I do want to say that even in 2015, our last report on harm really also reported we still have a long way to go in our efforts. We still have many quality and safety gaps. And this is one example of that recently, I think it was in 2015, McRae published this article that was highlighted in the Wall Street Journal that demonstrated that medical errors in hospitals are common and may now be the 3rd leading cause of death in the United States. And McRae makes a point that we really need to start putting on death certificates the true cause of death, and that would be the only way we'll be able to capture how common or the rate of error in our healthcare system is today. And the Journal of Patient Safety recently published that deaths from medical errors are equivalent to 10 jumbo jets crashing each week. And the National Patient Safety Foundation, which is now a part of IHI, also states that patients frequently are experiencing harms that could have been prevented or mitigated. And I know you are all nurses, you're out in the field, and I know you're quite aware of most of these statistics. But there is a lot of good news out there, and this was some interesting results from the National Patient Safety Program Partnerships for Patients, P4P, where they did demonstrate they were able to reduce hospital-acquired conditions and save lives and costs by really focusing. And as Deming would say, looking at the data, looking at the systems, and focusing on the change strategies. So we have a lot of barriers to performing quality improvement. And I think some of these barriers are attitudes from prior experiences with improvement efforts, concerns about priorities, that it isn't a priority, that it's our extra work. Another big barrier is not receiving any feedback on our efforts to improve. And then a lot of perceptions of why do we bother? This is just another fad. But I would like to say that I think that we really need to change these barriers and address these barriers and move to a culture of improvement. And in this culture of improvement, these are where our solutions are evident. Because you are all out there possibly doing improvement projects in cultures that really are not facilitating your work. But just think how it would be if we were in these environments, in clinics, in outpatient departments, where everyone was thinking about improving the work that we were doing, and that making our work more efficient and more evidence-based. And Don Berwick always talks about the fact that if we had these cultures of improvement, we would have more joy of work and we wouldn't be as burned out. So it is something for us to strive for. So how do we change our culture? How do we move from a culture of tasks to a culture of improvement? And I think that I often like to dream that a culture of improvement is this atmosphere where we have people are encouraged and rewarded for providing really quality-related information and care, but in which they're also clear about where the line must be drawn between what is acceptable and what is unacceptable behavior. And three key components of this culture of improvement are having a learning culture, where we can always receive feedback and learn from it and try to do it better the next time. I think that is really key, like being able to accept feedback and then take that feedback and think of a way to do it better. Another key component of the culture of improvement is designing systems where our systems are working with us rather than against us. And I know as nurses, we see this every day in our work, and that's why we probably do a lot of workarounds, because the systems in which we work are the biggest barriers to our care. And then managing behavioral choices is another key component of a culture of improvement. So I think then what we really need are superheroes to help us connect the dots to get us to these cultures of improvement. And you all know we are a force. Nurses are a force for healthcare improvement. In our work in inpatient and outpatient, we really have a good sense of what is happening and how we can improve things. And so let's think a minute about that. What are some characteristics of superheroes? Well, skip too fast. I was going to have you think about it for a second. Just share with me in the chat box a couple of things where you find that are characteristics of superheroes. Brave, yes, that's good. Strong, yes. Smart, good. Flexible, yes. Never give up. Proactive, assertive, positive. Invincible, I love it. Open to new ideas, that's a good one. Powerful, resilient. So let's breathe deep and think about these. Selfless, dynamic, wants the best for people, self-confidence, optimistic, common, optimistic. Awesome outfits. Yeah, awesome powers, I love it. Innovative. Great. These are excellent, excellent characteristics. Fearless. Right. And here's a couple patient advocates. Good. Then these were a couple that I thought of. Doing good. A lot of the ones you already discussed, I also have on this slide. One that didn't come up was the expert at workarounds. Physicians see us as expert at that, and that's not really such a good thing. Actually, I think the fact that we do work around many processes is not serving us well, because we're not addressing the root cause of the issues. We're working around it and not standing up for issues in our systems that aren't correct. Often work in teams. I like that, Anne. That's a good one. We have the superheroes that are now working in teams. Let's see. And acknowledging other strengths. I think that's another important piece, especially in our interprofessional work, that we have to really identify, what is that expertise of the other, and when do we delegate to them and when do we not. And we all need the support. That's right, Deanna. All right, so let's think about some superhero solutions. All right, so I guess the question then is, what can I do to foster a culture of improvement? So personally, as a nurse, and I think that there are things that we can do from a personal perspective on moving our cultures to this culture of improvement. And I think the first is just to stand up for what is right. I think we have a lot of examples of this where we just turn our cheek and watch errors go by. This is very common in all of our healthcare professional work, that sometimes it's very difficult to stand up when things are not actually going in the correct way. So we could tell stories to help with each other, to help us to think about when things are not going well, and spending some time to reflect on these issues and giving each other encouragement really to stand up when things are not right and think of solutions for how to improve things. So taking on that superhero and putting on your super suit. I think one of you did mention that you like the outfits of the superheroes. So we got to put on our super suits and we have to stand up and do what's right. And so we can make a commitment to that. And here are just a few statistics about standing up for what is right, or maybe not so much. So this is some research to demonstrate that clinicians acknowledge that they did not report error. For physicians, about almost 17% of them did report that they didn't report minor errors, and that almost 4% of them did not report major errors. And I've talked to my residents at the VA about this, and they say that they're medical residents, and they say that sometimes reporting errors is time-consuming, and they're not really quite sure what happens when the error is reported. And so they feel that it goes into this black hole, and they think, why bother? So that is a big barrier for why we're not standing up and reporting these things that are occurring that we need to address. And then Cohen reported that nurses, for almost 40%, again, not reporting an error that might be personally or professionally damaging. Again, this culture of blame in our healthcare environment is really a barrier, because we are afraid that we might lose our jobs for something that we think we are individually responsible for, but probably it is the system in which we work that is the cause. I think you're right. We have fear of being punished and fear of negative consequences. And we do need to change our systems and our cultures so that we can be open and share these issues so that we can improve. So the second strategy then for superhero culture change that is more improvement bound is to live by the guiding principles of the theory of profound knowledge, or that Deming's theory. And Deming's theory, again, I love his theory, so if you haven't studied it, it's a good one to integrate into your papers. And here are his 4 concepts of improvement knowledge. And I think that the superhero here is Spider-Man, because these profound concepts in his theory really bring together our improvement efforts and lead to a better culture of improvement. So knowledge of a system, we have a lot of tools that you're using currently to understand the system. One of them is the fishbone diagram or cause-effect diagram. And then we know that data is so important, and our tools here that serve us well for our culture of improvement are run charts and control charts. I think that unfortunately, most nurses do not understand run chart and control charts and don't use them and don't see the value in them, but we need to really up our competency in this area so that we are using these to demonstrate our improvement work. Knowledge of psychology is Deming's third concept that is so very important, and this is just one example of the Rogers adoption model where we can see that change is slow and that we do need to rely on our innovators and our champions to start the improvement movement in our micro systems in which we work. And then theory of knowledge is his last concept, and that is truly the model for improvement that you're learning or have learned on the IHI Open School modules, where you identify what you're trying to accomplish, how do you know if a change will be an improvement, and then what changes can you make, and then running these small experiments of change. So the sequential pieces, I love this little diagram that shows you start with a hunch or an idea, and then you run a PDSA and an experiment after experiment until you reach your improvement. But what does it really look like, and what does it really feel like? It feels like this. It feels very difficult and requires a lot of determination because the environments again are very complex. And I think, though, that as we move to a science of improvement, I think we're going to detangle a lot of these weighty lines. And I think we're going to understand things much better in the next 5 years as we really study these improvement efforts in a more vigilant way. Okay, that's the diagram of my life. That's good. Well stated, Erin. All right, so the next superhero solution is working in teams. And I know that everyone is saying that these days, you know, interprofessional teams is the key. But I wonder if it's not just the structure of working in these teams, but really the process. And I think the process that we have to get at is this feedback process, where we offer to our colleagues feedback, and that we can receive feedback from our colleagues. So when conflict does occur, we can address the conflict and share the power. And this is a key in our improvement work and something that we need to strive for. But as one of you had stated in the chat, the superheroes are moving toward teams too. So calling on the Avengers to move our culture of improvement forward. And the fourth strategy that I want to share with you today is the superhero strategy of engaging our patients and families in improvement. Have any of you put on your improvement team a patient or a family member to help you with your team efforts in your improvement? Anybody? Yes, great. That is very exciting. Oh, wow, I had a patient make a video. Yeah, definitely, if you haven't included a patient or a family member in your improvement efforts, really do that. I think they make a huge difference. They understand the systems that they're living in, and they have ideas as to how things could get better. Somebody said, meaning including them in driving the intervention. Maybe not so much in the implementation of the intervention, but maybe in the first side of that worksheet where you're looking at the systems factors, you're collecting baseline data, you're getting ideas from them as to what needs to be changed. Yeah, and patients who work in the system are even the best. So this is a newer model. There's just been a few articles out on the impact of patient and families on improvement teams, but I would encourage you all to really include these patients in your work ahead. So yes, patients and families can take on superhero characteristics also. Here is one article that was published, I think, in 2015 on patient partnerships in QI in healthcare services, and some of the challenges that they face with integrating the patients into their QI work. All right. And this is the fifth strategy for superhero solutions for how we can really change our cultures to cultures of improvement. And that is to make a commitment to personal improvement and systems improvement. And here I think about maybe the invisible girl as our superhero of choice for this one, where she's like invisible and she can sneak around all over and look at stand back and look at really our systems in which we're working in order to get a better perspective of the work we're doing. We recently, during our Nurses Week, we had that leader from who does all the work with structural empowerment and leadership. I can't remember his name. It's late here in Cleveland, Ohio. My bedtime almost. But he stated that his observation of nurses is that we're all running around and really not focused, and that we look a bit chaotic. And so I think that a culture of improvement would be where we can step back and look at what we're doing and try to organize our efforts. So I think a key here is like systems thinking, where we are moving from a personal effort, like trying harder, working harder, doing more, providing more individual care, to thinking about the care of the system. And I think that this is going to accelerate our improvement in healthcare quality and safety. So we've tinkered with this a little bit and wrote an article on this, and it's actually open access from the Online Journal of Issues in Nursing, where we have put some of our thoughts into this topic if you're interested in looking at it more. Basically what we're proposing is that we need to shift that paradigm from the individual care, which you see on the left, to the systems of care. Now, how does that look at a very simple example? And the examples below, you look at the left, I'll pass my patient's medications. Then you're moving now to, you're going to report when a medication error occurs. Then you move to, you're going to huddle with other nurses about why medications errors are occurring. So stepping back, looking at the system. Then you're going to find out what our medication error rate is on your unit. And then you're going to compare your medication error rate with other units to benchmark your care. So you can see where we're moving then to the system of care. This is really what we need to do in our work. And we also created a systems thinking scale to capture some of this, to see if we teach nurses about systems thinking, does it shift a measurement? And this is the tool that we've created, and it's open access, and it's available if any of you are interested in this in any of your work. And on that systems thinking too, I'm also having my students do a little system assessment and I send my all levels of my students, undergrad and graduate, into a unit, and I say, now look what's happening around you. It's hard for them to really step back and look at the systems and making systems observations. It's just a new skill set we have to start to teach. So the last superhero solution for improving our culture of improvement would be to be innovative. And this is something we don't teach a lot in any nursing program where I am from. But it is evolving and emerging in improvement. A lot of redesign talk and innovation, entrepreneurship. I think we need to get more curious about why what we're doing isn't effective. I think we have to defy tradition a little bit, and I think we need to ask a few more questions. All right, and so to get a little bit curious, I don't know if this is going to work, but we'll see. I will send you the link to this. It's a really quick video about being curious, and I think maybe that I might have lost the links in sharing these slides with all of you. But I will share that with you so you can look at it yourself. And here's a nice little video also, and I don't know if the link will work, to defy tradition. And that is how the pediatric hospitals now are putting window washers as superheroes and doing it a little bit differently, right? So not just putting up window washers to wash the windows, but really to let the children look out onto their windows and see superheroes cleaning their windows, creating some joy, doing things a little different, getting out of the old ways that we're doing things. And then the next one is the whys, asking more why questions. The video here link is where a little girl keeps asking her dad why. And it's a great little video, and I'll also send you the link after this so you can watch or use in your work ahead. So really what I went over was a little bit about what the QSEN Institute is doing and what QSEN has done in the past, and then looked at the current state of quality and safety in our current healthcare environments, and talked a little bit about the culture of improvement and how we really need to strive for this as a key factor to our work ahead in improving care. And then really addressing some superhero solutions that you may want to take hold of in your work ahead as you go forth as a nurse leader. So here again are the superheroes to the rescue: speaking up, using that theory of profound knowledge, having a team philosophy, engaging patients and families, seeing that whole system, and then being innovative. And so I call to you, the superheroes of the future. And remember that real change does not come from decree, pressure, permission, or persuasion. That real change comes from people who are passionately and personally committed to a decision or a direction that they help to shape. And so, as a superhero now, nurse, as you move forward, you can get involved with the QSEN conference. Next year, as I mentioned, is in Bonita Springs. If you have your QI projects that you want to disseminate, be sure to send in an abstract. Our call for abstract comes out in September and ends in December, and then our conference is in May. And I will assure you it will be a great conference. We have both practice and academic people there. Or if you want to use your superhero powers and submit a strategy onto our QSEN website, or if you'd like to start a task force, maybe you want to start a quality improvement task force because you want to do a collaborative across the country and share with other nurses all the great things that you have learned in your programs here. You're happy to start a task force. Remember that this QSEN Institute is a village, and it's open for ideas and open for you to get involved in and make an impact. Or as I do know, you are all already publishing your work using those Squire guidelines, getting those very important publications out that we can learn from what each of us does so that we don't keep making the same mistakes we're making. So I challenge you to be the superhero, do what is right and not what is easy. And so with that, I think I'm just about at that 40-minute marker and ready to take on some questions.
Great, there's a question there. Can you see that, Mary?
Yes, VA Quality Scholar. I can send that link too. I'll send the link to the VA Quality Scholars Program, and I'll send those links for those little videos.
Great.
And maybe if you can see, Judy, if there were other questions.
Yeah, I haven't come across any so far. I'm watching everybody. I do have a question for you. We have people implementing right now, and of course, they've just done their first cycle. What we do 2-week cycles of implementation. So they've just done their very first cycle, and many of them, of course, are a little discouraged that they haven't changed the world in the first 2 weeks. So you talked about failure as an opportunity. I wonder if you could just briefly hit on that for just a minute.
Right. Well, I do know that there are a lot of scholars who have written about this concept, and I can provide you with some resources and readings on that issue. And actually, there's an educator here in Cleveland who has written a book about it. So I'll just jot down here to send you the link to that book of, I think it's called Untangled. And that even as as Americans in kids in the United States, that we're not really teaching them this lesson of, it's okay to fail, right? Because as we fail, we learn about how we can do it better. We can step back, pause, look at the situation, and then identify sort of ways out or ways to do it better the next time. And so she actually proposes a whole new way to raise children in this mode of, hey, failure is okay. And I think that's how we have to be in healthcare too, in order for us to switch us to a learning environment where we pause, we step back, and we look at, like, what didn't go well here. If we think about the Toyota production system model, the lean model, this was one of the basic tenets of that model, in that they empowered that front line to recognize when they did fail or when things were not going well, and they empowered them to, like, stop the line, the manufacturing line. And when they stopped the line, they actually, caused a lot of productivity waste and a lot of lost funds for the company. But when they stopped the line, then a whole team of experts would come to the person who stopped the line, and they would ask the person, why did you stop the line? And then the person could explain, look, this isn't right. Something's not right here. And then they would problem solve as to why it wasn't right, and then they fixed it, and then they started the line again. So wouldn't that be cool if we could have that in healthcare, right? Like if, say, for example, the wrong medication was given, we could stop the line and we could step back and say, why was this given? What are the factors here? How can we ensure this doesn't happen again? So I think that philosophy of failure and seeing that as, a good thing, and a system or a culture where we embrace it is the key.
Thank you. There was a question, Lindsay Burson, who's in South Africa, asked if there are any international initiatives.
Oh, Brittany, that's a great question. Well, the International Task Force is alive and well. They are actually taking the first step of translating the competencies into different languages. So we have just recently posted a Spanish version as the first initiative. We are also thinking about maybe international collaboratives for improvement teams across the world, particularly related to how are we getting the competencies integrated into practice and also education. So join up. That'd be great to have you.
Susan Pantano has a question here. Oh, I just lost it. Hold on. People are adding more. Susan, if I can't find you quickly, go ahead and tell me what it was. Where did you go? Here it is. What strategies are being used in undergraduate nursing programs to encourage systems thinking versus task-oriented thinking?
Great question. So I think that is the foundation of QSEN, really switching that out. And as I mentioned, what we're doing at Case Western is really having students do systems awareness observations, and they are being able then in post-conference to talk about some of these systems issues. That's one strategy. There are games out there now to help the students to understand and appreciate the systems issues. We have on our website the Friday Night in the ER game, which is a great game to learn about systems. So there also are more strategies that are in that article I showed you. And then Ann Stalter has just published an article about the undergraduate strategies that can be used to promote systems thinking. And I think I'm on that article also. So if you just Google my name, then you'll get up some of these articles that are published regarding systems thinking.
Great. Ann Schaefer has asked, it seems like nursing as a field is better prepared for looming changes with tying reimbursement to quality of care. Is medicine looking to nursing to lead on this, and do you see more interprofessional collaboration as a result?
Okay, could you say that again? That was a lot.
Sure. Yes. She says, it seems like nursing as a field is better prepared for looming changes with tying reimbursement to quality of care. Is medicine looking to nursing to lead on this? And do you see more interprofessional collaboration as a result?
Okay, great question. I think that the underlying assumption is that all improvement work is interprofessional, that none of it should be one discipline doing the work. But we have a number of examples of where the opposite is occurring. So for example, in medical residency programs, the residents are mandated to do improvement projects, and they're doing them alone, okay? So at where I'm from, usually their projects are failures, and then they wonder why. They're not understanding the system. It's just sort of a disaster, you know, in some respects. There are wonderful models of interprofessional QI works. The University of Colorado has a wonderful program where they do work interprofessionally. The vision for continuing education, so there is an interprofessional continuing education organization, and their vision is that all continuing education will be interprofessional in the future, and that we'll be working in teams doing improvement work to get our CEs. So that'll be kind of a good, you know, a good way to structurally embed it into our systems so that we will work together to make improvements. I do think medicine, you know, is medical professionals are trained to be leaders, and they do tend to take charge. But I think as nurses, we need to stand up and share our view and share our expertise and be part of the power of movement in this interprofessional work.
There were a number of questions about our students are required to include patient engagement as a ramp that threads through their DMP projects, and there was a chat that went on about the struggle of using shared decision aids, decision tools, and with patient engagement. Do you have any advice or ideas about resources for them as they look to modify their tools or find ways to meaningfully engage? And then Melissa Mason, if you're still here, she had a comment on the patient engagement piece as well.
Yeah,
Dr. Dolansky.
Yes?
What's your idea?
Yeah, okay, so I just want to share, or is Melissa on?
Yes.
Great, will she be able to talk?
Melissa, can you turn your mic on? She'll get there.
Okay. I think this is a great area for more inquiry and more, you know, more input. I don't think we have good answers to how to do this. I'm in a quality group. We just met in Lake Maury, Vermont this past week, a whole week of just living and breathing improvement, and we invited patients there now to our group. And the bottom line is, you know, they don't really know how to get engaged either. So we need to move forward and thinking about how do we do this in a better way. And I'm not sure decision aids are the answer. I think that this would be a great topic for another session, just to talk about how to engage patients. Be a great article. Oh, there we go. The IHI video was awesome on shared decision making.
Can everybody hear my mic now?
Yes.
Yes.
Okay. So I'm sorry, what exactly were you wanting me to answer or share?
Well, you had brought up the nuance of taking, of how to engage patients as actually drivers of change. So can you share what you did?
Yes. So in my last cycle, we were using shared decision-making aids, and when they were getting used, the patients actually really liked it. But it was really hard to get the physician to remember to use them. we had really variable usage rates. And so what we ended up doing was having the patient, so having front desk and the medical assistants talk to the patients when they gave them the decision aid to say, now listen, Dr. So-and-so and Melissa would like for you to remind them to go over this with you when they're in the room. So definitely bring it up if they forget, if the visit gets too busy. So they got 2 reminders from staff to say, hey, make sure that you ask the providers to go over this with you. And that actually helped a lot. And we had, you know, patients actually stopping us and going, oh, by the way, you didn't go over my form with me. You know, if the visit was ending. And so that was kind of a neat way to bring patients in and get them involved as driving the intervention.
Yes, that's a great strategy, Melissa. And actually, it's an evidence-based change strategy, implementation strategy called consumer-driven, where you have the consumer drive the change.
Yes.
Yeah, very nice.
And I just... Tematopi's also looking here at time is a great barrier to implement decision aids in a busy clinic. Do you have any thoughts on that?
I do not. Maybe another student might. A good decision aid can often save time.
Mm-hmm.
Make it simple, right? I think those are the keys, really. I think simplicity and very simple rules are key. Anything that's too complex isn't going to help us with our efficiency. Okay, yeah, I'll send you like a list of some resources, which would include the QSEN Institute abstract submission site or the conference site. And I'll keep in communication with Judy and giving her sort of updates. And if anybody wants to be on the QSEN newsletter, we send it out every month. If you want to send me a list of names, I can also add you to our newsletter list. Has a lot of really important publications and other kinds of announcements.
Great.
Somebody also asked.
Let's see.
Go ahead.
It says, within my setting, the decision aid was a really engaging tool. We found that using it changed how patients talked to us and how they saw us. And that was from within the incarcerated population.
Right. Yeah. I mean, that is the key, right? To really get the view, hear the views of the patient. That's what we all really want, isn't it? Just to be heard. That's beautiful. And incivility came up, I know, in a couple of the chats. And we're finding that that is a huge barrier to a culture of improvement. And we are thinking about strategies for addressing incivility. And there's a lot written in that area.
Okay, does anyone have any last questions for Dr. Dolansky?
As you can see, it got dark here.
Yes, yes.
I don't have access to light.
Well, thank you so much for presenting to us. We will record this and, of course, get everybody, as many as we can, signed up with QSEN and present to hopefully have some students present there next year. Dr. Slager did say we did have one student present at QSEN this year. Oh, we're losing you.
Yes. I think that I will share the person who was presenting at QSEN this past year. Also, if anybody has DNP practicum hours, I'm happy to facilitate a practicum experience for anybody. So that's another area where you could get involved.
Oh, great. All right. Well, I think we are out of time. Thank you so much for presenting with us. We are so very grateful. And this will be recorded, as I said, so we can all listen back on it again.
All right. Thank you for having me here. It was a delight. And good luck to all of you. May the force be with you to improve quality and safety.
Thank you so much. Have a good night.
Thank you. Bye-bye.